Us again for another Quesmed session. I've probably seen a couple of my lectures before. I lecture on obstetrics, gynecology and sexual health. So I'm a locum doctor. I work part-time in sexual health and obs and gynae, and I spend the rest of my time as an editor for Quesmed. So a few housekeeping things first of all. The format of this lecture will be single best answer questions, similar to those that you might encounter in your final exams. And it is going to be interactive. I will show an example SBA question. You'll have a poll pop up and I'll ask everyone to submit their answer. I'll normally give 60 seconds for you to read the question and to submit an answer. That is sort of indicative of what you'd be expected to do in your final exams. I will fire through this lecture fairly quickly. I'm aiming to finish the session within an hour or so, but like we said, the lecture will be recorded and uploaded to YouTube after, so you can watch it back if you've missed anything or you want to recap anything. And yep, pop any questions in the chat box and I will answer as many as I can, and I'll have a wee look at the end as well to see if there's anything we've missed. Okay, so let's crack on. Today we're talking all things medical obstetrics. We're going to talk about diabetes, hyperthyroidism, rashes, VTE, hypertension, HELLP syndrome, and some common infections that we encounter in obstetrics. So we are going to crack on straight away with the first question, and I will give you 60 seconds to read the question and to submit an answer in the poll that will pop up. Wonderful. So thank you very much for everybody answering that question there. Most people are answering B, a family history, or C, her BMI. So thank you for participating. So what's the deal with diabetes in pregnancy? So the definition of diabetes in pregnancy is a glucose intolerance that develops for the first time during pregnancy. And why are we worried about it? Well, diabetes in pregnancy is associated with a whole host of increased risks, including fetal macrosomia, so big babies, and therefore increased risk of birth trauma, birth complications, shoulder dystocia. People with uncontrolled diabetes in pregnancy are more likely to require induction of labour or a caesarean section. And babies born to mothers with uncontrolled diabetes are more likely to suffer from neonatal hypoglycemia and perinatal death. So that's why diabetes in pregnancy is important. So who do we screen for diabetes? Well, there's a list of risk factors for gestational diabetes. These are a BMI of more than 30, a history of having a big baby weighing more than 4.5 kilograms, a family history of diabetes, and that means a first degree relative with diabetes, so parent or sibling, or if you come from a family origin with a high prevalence of diabetes, and these include people from South Asia, people from the Caribbean, and people from the Middle East. So let's check back with our question here. I've highlighted a few of the key points here that might draw your attention. We've got a woman here that's 38, she's German, she's got a BMI of 31.5, she's got a history of PCOS, she's had a previous healthy delivery, sounds like it's a normal weight, normal gestation, and it says her maternal grandfather and cousin have diabetes, and she admits to having a sweet tooth. So it sounds like her diet isn't great and she likes some sugary things. So the single thing mentioned here that merits referral for an oral glucose tolerance test is her BMI. Anyone with a BMI over 30 is recommended to have an oral glucose tolerance test. So although, looking at the other answers there, although incidence of diabetes and gestational diabetes does increase with age, there's no particular cutoff that merits a glucose tolerance test based on the current guidelines. And in the current guidelines, it's not just any family history we're interested in, it's a family history of a first degree relative. So although her maternal grandfather and her cousin have diabetes, neither of them are a first degree relative, so they don't actually count, although we take this into account when doing our full risk profile. A disclosure of dietary preferences certainly merits some discussion and promotion of a healthier diet, but it doesn't necessitate screening. And ethnicity is important, and those with Asian and Afro-Caribbean descents are most at risk, so her German heritage doesn't put her at increased risk. So the correct answer there was BMI. So let's move on to the next question. Again, you will have a minute to read the question and submit an answer via the poll. Lovely, thank you for participating there. So we've got a toss up here between A, trial of changes in diet and exercise, and E, repeat the oral glucose tolerance test in 1 week. Some people also think we should start metformin and some people insulin. Nobody thinks we should start glibenclamide, so that's good. So let's just quickly revise what goes on in an oral glucose tolerance test. So this is done at 24 to 28 weeks in women at risk. So firstly, the pregnant person will attend the clinic having fasted and will have their fasting glucose taken. They will then be given 75 grams of glucose, and that's usually in the form of a glucose drink. And their glucose levels will be checked again 2 hours post-glucose, because we're looking to check glucose tolerance. And the diagnostic criteria for gestational diabetes is a fasting glucose of 5.6 or above, or a 2-hour glucose of 7.8 or above. So those are the key numbers to remember. In terms of management, all women with a diagnosis of gestational diabetes should be seen at an antenatal clinic within a week. They should also be referred to a dietitian and counselled on how to check their own blood glucose. They should also be given appropriate lifestyle advice, including changing their diet to include more foods with a low glycemic index and to introduce or increase regular exercise such as walking. In terms of management, if the fasting glucose is less than 7, we can try a trial of lifestyle modifications first. A review should take place 1 to 2 weeks later, and if blood glucose is not improved, we think about introducing pharmacological management with metformin. If metformin isn't working, we then think about insulin. If insulin's unacceptable, we're then thinking of glibenclamide, which, remember, that's a sulfonylurea and an oral anti-hyperglycemic. And remember, those sulfonylureas, they work by inhibiting those ATP-sensitive potassium channels, which lead to depolarization of the pancreatic beta cells and promotion of insulin secretion. In women whose fasting glucose is greater than 7, we go straight to insulin, with or without metformin. Again, if insulin is unacceptable, we can consider glibenclamide, as that is an oral medication. So checking back with the question, she's going to have a diagnosis of gestational diabetes here, isn't she? As both her fasting glucose is above 5.6 and her 2-hour glucose is above 7.8, 8.1 at the moment. So because her fasting glucose is under 7, she would be one of these patients that are suitable for a trial of lifestyle advice. So we don't want to try this lifestyle advice for too long, as we don't want to leave this untreated. So we can try that for 1 or 2 weeks and see how her glucose goes. If after 2 weeks or so her glucose measurements fail to improve, we can think about metformin. And if they're still no good, we can think about insulin. There's no guideline for repeating an oral glucose tolerance test, as it's meant as a screening test. We don't generally repeat that. And from now on, we do want her to check her glucose regularly, and we want to use those numbers to see how her glucose monitoring is going. So the correct answer here is a trial of changes in diet and exercise in the first instance. So let's move on to the next question. And here we've got a woman with some symptoms, and I'll give you a minute to read the question and formulate an answer. Lovely, thank you for answering there. So let's talk about hyperthyroidism in pregnancy. So most cases of hyperthyroidism in pregnancy are in people with known hyperthyroidism. Because remember, hyperthyroidism untreated is associated with a reduction in fertility. So it's actually quite uncommon to have a first diagnosis of hyperthyroidism in pregnancy, but it does happen. So just revising the general symptoms of hyperthyroidism, these are mostly the same as any non-pregnant person with hyperthyroidism. So tachycardia, arrhythmia, tremors, sweating, weight loss. In pregnancy, there might be a failure to gain weight appropriately with gestation. In terms of causes, the most common causes in pregnancy are Graves' disease and gestational hyperthyroidism or gestational transient thyrotoxicosis. Other causes are adenomas and multinodular goiters, as in non-pregnant people. A wee reminder on Graves' disease. So remember, that's an autoimmune condition characterised by antibodies to the TSH receptor. So TSH receptor antibodies, or TRAB. And these stimulate the thyroid gland to produce thyroid hormones T3 and T4. Remember also the specific eye signs of Graves, those sticky out eyes, that exophthalmos. And Graves' disease is also associated with a goiter. In terms of testing, Graves' disease will have a high T3, T4, a low TSH, and you will have a positivity for those TRAB antibodies. And management generally is with anti-thyroid drugs. So let's have a wee chat about this gestational hyperthyroidism or gestational transient thyrotoxicosis. So that's not autoimmune in nature, and instead it's thought to be due to the rising HCG levels. And it typically arises early in pregnancy, about week 7, and usually spontaneously resolved by after week 20. And it's strongly associated with hyperemesis. The high HCG directly stimulates the thyroid, causing a rise in thyroid hormone synthesis. Management is generally supportive, and as the condition will spontaneously resolve once the HCG levels settle down. However, you'd obviously manage any nausea and vomiting. So let's think about management of hyperthyroidism. So it's a bit tricky in pregnancy. We obviously cannot use radioactive iodine at any stage of pregnancy, as that's really teratogenic. And remember, even people on radioactive iodine are advised to avoid pregnant people. That's how teratogenic it is. So that is a total no-no. Carbimazole is associated with defects such as esophageal atresia and fistula when used in the first trimester. So we tend to only use that in the second and third trimester, as it is teratogenic. And propylthiouracil is associated with some liver toxicity when used in the first and the third and fourth trimester. So we tend to use that in the first trimester. Surgery that is rarely carried out in pregnancy just due to all of the risks of associated risks of anaesthesia and operative trauma. And beta blockers, well, they might be used for symptomatic management, but prolonged use in pregnancy is associated with growth retardation, and obviously that's not treating the underlying problem. So just let's go back to the question. We've got a woman in her second trimester who's got classic signs of hyperthyroidism. The STEM hasn't specifically mentioned a goiter or any eye signs, but her T3 and her T4 are high, aren't they? And her TSH is low, and she is positive for those TRAB antibodies. So the diagnosis here is Graves' disease. And she does need treatment for this. Leaving Graves' disease untreated in pregnancy increases the risk of miscarriage, placental abruption, preterm delivery, and a whole host of other problems. Like we said, we can't give radioactive anything. Propranolol, that might help with symptoms, but it's not going to address the underlying diagnosis. There's obviously no reason to recommend termination of pregnancy. Levothyroxine, well, that's for hypothyroidism. So the correct answer here is carbimazole. The question might have been made harder by giving you the option of carbimazole and propylthiouracil. So you'd have to remember that it's carbimazole is used after the first trimester. So let's move on to the next question, again 60 seconds. Wonderful, thank you for participating. So let's think about some pregnancy skin stuff. So let's start by thinking about intrahepatic cholestasis of pregnancy. And this is often just referred to simply as obstetric cholestasis. So this happens when bile acids build up, and this causes abdominal pain, nausea, appetite loss, and pruritus, so itching. In this condition, there's not typically a rash, but the condition is very itchy, so there might be evidence of sometimes quite extensive excoriations. And the itch is characteristically worse on the hands and feet. Other signs include deranged LFTs, elevated bile acids, dark urine, jaundice, and problems with clotting. It's treated with ursodeoxycholic acid, which acts by displacing the problematic bile acids from the bile acid pool, therefore improving liver function and relieving that itch. Adjuncts include an antihistamine, so something like chlorphenamine, and they may also need vitamin K to reduce the risk of hemorrhage, and early delivery if the woman is in the third trimester. Other skin stuff, Striae Gravidarum, the most common skin thing to be seen in pregnancy, and put simply, that's stretch marks. These are linear scars that occur usually on the abdomen, but also on the buttocks or thighs. It's thought to be to do with the relaxation of connective tissue during pregnancy, and it doesn't usually resolve in itch or inflammation. And there's not really an effective treatment for this, it's just sort of accepted as part of pregnancy. However, we can recommend a simple emollient. Eczema often flares up in pregnancy and presents pretty much the same as in a non-pregnant person. That dry skin, the cracks, the sores, and mostly affecting the flexor surfaces, so inside the elbow, the back of the knee, and it is itchy. And it's managed in the same way as a non-pregnant person with emollients and a topical steroid if required. So Pemphigoid gestationis is a rare skin condition occurring usually in the second or third trimester. It typically starts around the umbilicus and results in an itchy raised rash with plaques. These plaques typically develop blistering within 1 or 2 weeks. And again, the treatment is emollient and topical steroid, but that's quite a rare condition. Polymorphic eruption of pregnancy, or PUPPP, pruritic, urticarial papules and plaques of pregnancy. It's a bit of a mouthful. And that typically starts in the striae, and it can progress to the buttocks or the thighs. And it presents again as an itchy, raised rash, and it usually occurs in the 3rd trimester. And again, you might have guessed, treatment is with emollients and topical steroids. So let's check back with the question. Looking at the answers here, intrahepatic cholestasis doesn't tend to produce a rash. It tends to produce more of an itch. So this is more unlikely, and she's got no change in her liver function tests. Striae, this doesn't sound like simple striae. There's a papular rash and there's an itch. Eczema, well, it's not really the distribution here, and while it can read itself for the first time during pregnancy, there's usually some history of it. Gestational pemphigoid, yep, that usually does start in the abdomen, but it's rare, and there's no mention in the stem here of that blistering. So the correct answer here is E, polymorphic eruption of pregnancy, which most of you guys put, so well done. Moving on to the next question, again, you'll have 60 seconds to read the question and submit an answer in the poll. Lovely, thank you for participating there. We've got a lot of people going for B, D-dimer, and C, ventilation, perfusion, lung scan, VQ scan. So let's think about chest pain in pregnancy. So chest pain in pregnancy is mostly investigated with pretty much the same way as any chest pain, with some caveats of some things being more common in pregnancy, such as venous thromboembolism and reflux. And there's also some pregnancy-specific things that can cause a chest pain, such as the upper abdominal pain of pre-eclampsia can be construed as chest pain. Initial investigations are the same as a non-pregnant person. We want to do bloods, we want to do a chest x-ray, making sure to shield the abdomen, and we want to do an ECG. And I've just highlighted there venous thromboembolism because we are obsessed with that in pregnancy. The reason we're worried about this is that the risk of VTE is increased 4 to 6-fold by simply being pregnant. And VTE obviously includes both pulmonary embolism, PE, and deep venous thrombosis, DVT. So for patients with symptoms of a DVT, we want to think about doing a Doppler ultrasound. So symptoms such as leg swelling, pain, redness, or any discrepancy in the calf circumference, we want to think about a Doppler ultrasound looking for a DVT. And for patients with symptoms of PE, so remember that's chest pain, shortness of breath, hemoptysis, we're going to opt for a VQ scan. The reason we tend to go for a VQ scan over a CTPA is because the dose of radiation to the mother's breast tissue is less, and CTPA is associated with a greater lifetime risk of breast cancer. So it's actually not so much to do with the radiation to the fetus, it's actually more to do with the radiation to the mother. For suspected VTE in pregnancy, we have a low threshold for just giving treatment, and treatment is usually with a low molecular weight heparin. And even if there's just a sniff of a VTE, we normally treat while we wait on definitive investigations. And for a confirmed VTE, the pregnant person will normally remain on low molecular weight heparin throughout their pregnancy. So looking back at the question here, we've got a woman in her 3rd trimester and she has shortness of breath and chest pain. Observation, she's tachycardic and her SpO2 is down a little. Everything else seems normal, and we've already done those preliminary investigations. So we've done blood, chest x-ray and ECG. So what's next? A high resolution CT of the chest? Well, no, we don't want to be doing high resolution, high radiation scans of the chest if we can possibly avoid this. We would consider doing a CTPA if a VQ scan was unavailable or if the woman opted for that, but we wouldn't do a high resolution CT of the chest. That is a different investigation from a CTPA. A D-dimer, now a D-dimer is raised in pregnancy itself, and there's not an established cutoff for D-dimer. So D-dimers are not particularly useful in pregnancy, as if it's positive, it doesn't necessarily mean there's a VTE present. Ultrasound of the limbs, well, we'd think about that if there was leg symptoms present, but in this case, she's definitely sounding more like she's got a PE rather than a DVT, isn't she? An ABG, well, that might reveal a hypoxia, but since we're already thinking PE, the most appropriate investigation is that VQ scan. So the correct answer here is C, VQ scan, and that's going to give us a definitive diagnosis of a PE if it's there. So let's move on to the next question. Again, you'll have 60 seconds. Lovely, thank you for participating there. So let's talk about hypertension and elevated blood pressure in pregnancy. So let's think about a few definitions first of all. Chronic hypertension, that is hypertension that was pre-existing prior to pregnancy. So anyone who's already diagnosed hypertensive. Pregnancy-induced hypertension is a blood pressure over 140 systolic or over 90 diastolic in a pregnant person who had a normal blood pressure at booking, who is asymptomatic and has no evidence of proteinuria. Pre-eclampsia, that's when the blood pressure is over 140 over 90, with either evidence of proteinuria, systemic involvement, so something like deranged coagulation, abnormal kidney function, abnormal LFTs, or if she has symptoms, so headache, visual disturbance, epigastric pain, peripheral edema. And eclampsia, well, that's essentially pre-eclampsia with seizures. So checking back with the question here, we've got a woman who's well, but she's got elevated blood pressure. So what's the diagnosis? Well, it's certainly not normal, as it's over that threshold of 140 over 90. There's no mention of her having hypertension prior to pregnancy, so I don't think it's chronic hypertension. Is it pregnancy induced? Well, it's elevated, but everything else is normal. There's no evidence of proteinuria and there's no symptoms. So the correct answer here is pregnancy induced hypertension. Now, it's not pre-eclampsia because there's no evidence of protein, there's no evidence of organ dysfunction, and there's no evidence of symptoms. And it's not eclampsia as this woman doesn't have any seizures. So moving on to the next question, again, you'll have 60 seconds. Lovely, thank you for answering. So most people are going for D, IV magnesium sulfate. So let's have a further chat about pre-eclampsia and eclampsia. So pre-eclampsia typically comes on after 20 weeks, and like we said, it manifests itself as hypertension with proteinuria. Other symptoms and signs include peripheral edema, headache, drowsiness, visual disturbance, epigastric pain, nausea and vomiting, and hyperreflexia. Now, preeclampsia is thought to be placental in origin and starts way back when the placenta first implants. And it's associated with abnormal placentation at the start of pregnancy. Risk factors for developing preeclampsia include nulliparity, previous history or family history of preeclampsia, and again we're thinking about mums, first degree relatives, increasing maternal age, pre-existing disease, so things like hypertension, diabetes, renal disease, autoimmune disease, and obesity, and multiple pregnancies. So pre-eclampsia management is with antihypertensive therapy, and in pregnancy we generally use labetalol and nifedipine. If the woman is at risk of seizure, or if the preeclampsia is severe, we might already give magnesium sulfate to try and reduce the risk of seizure. And ultimately, the only cure for preeclampsia is delivery of the fetus. Thinking about eclampsia, eclampsia is that scary situation where there is preeclampsia, so remember blood pressure over 140 over 90, with either evidence of proteinuria, systemic involvement or symptoms. However, this also includes seizure activity. So it rarely happens because we usually do manage to catch preeclampsia before it becomes eclampsia. But that is with seizure activity. And management of seizure activity in eclampsia is with IV magnesium sulfate. And again, the only cure for this is delivery of the fetus. So let's check back with the question here. The correct answer most of you got was IV magnesium sulfate. IV lorazepam, now that's generally reserved for non-pregnant patients or pregnant patients that have a history of epilepsy and seizures. IV phenytoin, that's used if seizures remain uncontrolled following administration of your IV magnesium sulfate. IV ketamine, well that's an anaesthetic drug and that is usually used and can be used for induction of anaesthesia, and it's not really appropriate for treating eclamptic seizures. And IV sodium valproate, again that can be used as a second line drug to treat ongoing seizures. However, sodium valproate is teratogenic, so we do try at all costs to avoid that in pregnancy. Moving on to the next question, and I'm going to give you 90 seconds to read this question, formulate an answer, just because there's quite a lot to read in this one. Lovely, thank you again for participating in the poll. So most people are going with B, HELLP syndrome. So let's talk about some liver stuff. Let's start by chatting about the acute fatty liver of pregnancy. So this is rare, it usually occurs in the 3rd trimester, and what's happening here is there's a progressive accumulation of lipid in the liver, essentially eventually leading to liver failure. Patients often present with non-specific symptoms, so anorexia, nausea, vomiting, fatigue, headache, abdominal pain. On physical examination, the patient can usually have a fever and maybe jaundiced. And in terms of lab findings, you might see hemolysis, you might see elevated LFTs, particularly elevated AST and ALT. And the management is delivery. So let's think about HELP syndrome. So this stands for hemolysis, elevated liver enzymes, and low platelets. Again, it most often occurs during the 3rd trimester and is part of a spectrum of hypertensive disorders with a similar etiology to pre-eclampsia. Clinical features are similar to pre-eclampsia, with right upper quadrant pain, visual changes, peripheral edema, and hypertension. And again, management is with delivery. However, people may need blood transfusion and steroids if there's marked abnormalities in the full blood count. Cholestasis of pregnancy, we've already spoken about that, but as a reminder, this is a buildup of bile salts leading to abdominal pain and that intense itching. I'm not going to go through that slide again, we have already gone through that. So let's check back with this question. The correct answer here, as most of you got, is HELP syndrome. So let's check with the other answers though. Acute fatty liver of pregnancy. That's characterised by your epigastric pain and your abnormal LFTs. Often is associated again with hypoglycemia and hyperuricemia. And hypertension is normally mild. HELP syndrome, yep, this is fitting the bill. Hypertension, proteinuria, maybe some hemolysis causing that low hemoglobin there, elevated liver enzymes, and definitely low platelets there. So she's fitting the bill there for HELP syndrome. Acute hepatitis, that might well cause elevated liver enzymes and epigastric pain, but it wouldn't normally cause low platelets or cause hemolysis unless it was severe. The patient also has no history of fever and no risk factors that might suggest a hepatitis. Obstetric cholestasis, remember that is that intense itching and elevated bile acids. Doesn't tend to cause low platelets or hemolysis. And pre-eclampsia, we've kind of already went over that. That's characterised by hypertension, proteinuria, edema. We've already gone over that one. So she is mostly fitting the bill for HELP syndrome. She's ticking all of the boxes there. So moving on to the next question. Again, you'll have 60 seconds to formulate an answer. Lovely, thank you for answering. Most people are going for D, vulvovaginal candidiasis. So let's think about vaginal discharge in pregnancy. Now, pretty much every pregnant person will have an increase in vaginal discharge, so it's actually quite a common presentation. Other reasons for discharge include things like rupture of membranes, and a normal rupture of membranes produces clear odorless liquor, and that's normal. And that can be anything from wet underwear to a trickle to a gush of fluid, and that is a normal spontaneous rupture of membranes. Variations include things like a chorioamnionitis, which may present as a foul-smelling yellow or green-tinged liquor, and that may be accompanied by fever, abdominal pain, or evidence of fetal distress. Another variation of rupture of membranes is meconium-stained liquor, which is a brown or yellow-stained liquor, which is associated with fetal distress. Infections, well, a pregnant person can have all the same infections as a non-pregnant person. Common things are things like bacterial vaginosis, BV, which typically causes a grey or white watery discharge with a characteristic fishy odour. Candida, that's very common in pregnancy, and that causes a typical lumpy white cottage cheese-like discharge, which may have no odour or may have a sour odour, and it may include a vulval itch. STIs are obviously a common thing in pregnancy as well. Chlamydia, gonorrhea, these may or may not cause discharge. They may or may not cause abnormal bleeding in pregnancy. And other STIs such as trichomonas, that typically produces that frothy yellow discharge. And group B strep, that can sometimes cause a discharge, but in some cases can cause a yellow or green discharge, but in most cases doesn't really cause much symptoms. So checking back with our question here, we've got a young pregnant woman at 34 weeks gestation, and she has got a thick, white, itchy discharge. Now, I don't think that sounds like BV. BV tends to be more of a copious discharge and tends to be typically smelly. She's not really got any risk factors for STIs, so I don't think it's gonorrhea or anything like that. Mucus plug, well, this sounds more like an ongoing discharge rather than a one-off expulsion of a plug, and a mucus plug expulsion wouldn't tend to cause itch. So I think this sounds like Candida, with the itch, the thick discharge, and the fact her vulva looks red and irritated. And thrush infections are often worse after coming out of the bath, particularly if the woman is using soap or hot water to try and clean the vulva. And I don't think it sounds like a normal discharge. A normal discharge doesn't tend to be thick and doesn't tend to cause an itch. So the correct answer here is vulvovaginal candidiasis. And in pregnancy, again, this is super common, and we always do treat this, as it can cause what we call an irritable uterus, and it can stimulate uterine contractions or irritability. So we do treat this, and we treat it with intravaginal clotrimazole. We try and avoid oral azoles in pregnancy as they are associated with teratogenesis. So let's move on to the next question, and again, you'll have 60 seconds to pop a wee answer in the poll box. Lovely. So we've already sort of gone over this one, haven't we? So the correct answer here is chorioamnionitis. I don't think it's BV, as like we said, that discharge is typically grey, clear, white, doesn't tend to cause things like fever. I don't think it's a urinary tract infection, although this yellow watery fluid does maybe sound like urine. This definitely sounds more vaginal in origin, and a UTI wouldn't, she's not mentioned any other kind of symptoms of UTI, so I think that's less likely. Sepsis, yep, she could be heading towards sepsis. She's tachycardic, she's got a fever, but it's not a sepsis of unknown origin, is it? We know the origin, it's pretty obvious where the origin of this infection is, so I don't think it's sepsis of unknown origin. And intrauterine death is a possibility, but she notes her baby has been less active, but not active at all. So the correct answer there is, you're right, chorioamnionitis. Well done. So moving on to the next question. Perfect. So we're all going with acyclovir, but a bit of discrepancy in what dose and route we're using here. So let's talk about herpes simplex in pregnancy. So it presents in pretty much the same way as in the non-pregnant person. Normally presents with multiple painful genital ulcers. And quite often there's a history of previous symptoms. And this is normally a flare of the HSV. Why are we bothered about herpes? Well, because of neonatal herpes. So this is transmitted to the baby during childbirth. And 70% of infants that do contract neonatal herpes have some involvement of their nervous system. And these babies tend to present late with non-specific signs, and the mortality even with antiviral treatment is around 6%, and there is a 70% chance of having long-term neurological morbidity. So it's really important that we treat HSV in pregnancy and try and prevent neonatal herpes. Management of herpes in pregnancy is with oral acyclovir following clinical diagnosis, and the dose is 400 milligrams 3 times per day, and that is usually continued for 5 days. If it's contracted in the first or second trimester, we'll normally advise a daily suppressive therapy from 36 weeks gestation. And the whole point of that is to try and reduce the chance of her having another flare later on in pregnancy and passing it on to the baby. HSV lesions at term, so if the person has herpes lesions at term, that is an indication for delivery by caesarean section, just due to the high risk of transmitting it to the baby. And C-section is also recommended for all women who've had a first outbreak of herpes in their 3rd trimester, again because the risk is that bit higher. So checking back with the question here, the correct answer was oral acyclovir 400 milligrams 3 times a day. Let's check the other answers. So topical acyclovir, that doesn't really play any role in the treatment of genital herpes. Oral acyclovir at a dose of 400 milligrams twice per day is the usual suppressive dose for a non-pregnant person. In pregnant people, the suppressive dose is the same as the treatment dose, 400 milligrams 3 times per day. And we generally give that, like I said, from 36 weeks. IV acyclovir, now that is indicated for women that maybe have disseminated disease or they have CNS involvement. This patient seems to be otherwise well, so she's not needing IV. And topical lidocaine, that might be useful for symptomatic relief of herpes, particularly if the lesions are so painful that they're stopping the woman from being able to urinate or being able to sit down. They can be sometimes so painful that you do need topical lidocaine. But that's obviously not treating the herpes, which is our primary concern in this case. So moving on to the next question, we're almost there, guys. Lovely, thank you for answering. So most people going with B, oral antibiotics, with a few of you going for the other 4 answers. So this is basically asymptomatic bacteriuria in pregnancy. And that's defined as a positive urine culture in pregnancy without any symptoms of UTI. And asymptomatic bacteriuria is always treated in pregnancy with an appropriate antibiotic. So typically this will be cefalexin or nitrofurantoin, depending on sensitivities if you have them. This is because untreated UTI is associated with an increased risk of spontaneous miscarriage and preterm labour. So we always treat it. And if group B strep is identified, the woman will also require intrapartum antibiotics. So the correct answer here is B, oral antibiotics are recommended. Looking at the other answers there's Obviously A is incorrect. There's no indication to perform blood cultures unless this woman's septic and we're doing sepsis 6. She doesn't need an ultrasound scan. It doesn't sound like there's any indication of structural abnormality or obstruction. And there's no need to perform a repeat culture when we already have a positive culture. So moving on to the last question. Lovely, thank you for answering these here. So this is talking about group B strep in pregnancy. So let's just have a chat about group B strep. So what is group B strep? This is a common commensal bacteria. It occurs happily in about 25% of people. The reason it's worrying in pregnancy is that it can cause a neonatal group B strep infection, and that's the most common severe infection to occur in neonates. So there's risk factors for having a neonatal GBS infection, and these things include positive culture in a current or previous pregnancy, a previous birth with a neonatal GBS infection, things like preterm labour, things like prolonged rupture of membranes, things like having an intrapartum fever, or evidence of chorioamnionitis. Now, all mothers who carry group B strep will be offered intrapartum antibiotic prophylaxis, and that's from the onset of labour to help prevent transmission of the baby. Unlike herpes though, having group B strep doesn't preclude vaginal delivery or doesn't necessitate immediate delivery. So let's have a check at the answers here. So the correct answer here is oral antibiotics. The crux of the problem here is that she has a UTI, she has symptoms, so she does need treatment with oral antibiotics. She doesn't require IV antibiotics because she's not septic and she's not in labour. However, she would require IV antibiotics during labour. She doesn't require elective C-section, as we said. Having group B strep does not preclude vaginal delivery. And there's no indication for induction at 35 weeks here. However, if and when she does go into labour, she would get IV antibiotics. And we don't just leave group B strep, we do offer antibiotic treatment and IV intrapartum antibiotics. So the correct answer here is oral antibiotics today, because at the end of the day, she's got a UTI, we need to treat that. So that's us come to the end of our lecture. I have tried to answer most of the questions in the Q&A box, so I hope you can see my answers there. I think I've answered all of the questions that have been answered here. Any further questions, pop them in the chat box. I'll leave that open for a wee 2 minutes. You will also see in the chat box a form to fill in your feedback. I'm very grateful for any feedback, whether you liked the questions, were they too easy, were they too hard, what did you think of the lecture length, is it too short, too long? Grateful for any sort of feedback that can help us to improve Quesmed lectures. So all that's left to say is thank you very much for attending this lecture. Very grateful for your participation and hope to see you at a future Quesmed session.